I'd like to welcome everyone this afternoon to this Medscape Oncology live stream. Today, we're going to be talking about multidisciplinary team care in endometrial cancer, the responsibilities of the care team. My name is Pam Soliman, and I'm a GYN oncologist at MD Anderson Cancer Center in Houston, Texas. And I'm joined today by two of my colleagues that are part of our multidisciplinary team, and I'd like them to introduce themselves as well. Donyika.
Hi, everyone. My name is Donyika Joseph. I am one of the clinical pharmacists on the Gynecology Oncology team at MD Anderson.
Hi, and I'm Dr. Barrett Lawson. I'm an assistant professor in pathology, and so I assist with anatomic and clinical pathology here.
So we're really happy to be here together to talk a little bit about some of the changes in endometrial cancer care and how it's really important that the team works together to make sure that patients are getting the best care. So I imagine many of us on the call today have taken care of patients with endometrial cancer. So some of this is a refresher, but endometrial cancer is the second most common gynecologic malignancy worldwide. For those who practice in the United States, it's actually the most common cancer that we see and treat. I think other important things are we know that the overall incidence of endometrial cancer has been increasing over the years, as well as the increase in mortality rate. And this is very different than many of the other cancers that we see and treat, especially in the United States. First-line therapy for patients that have an advanced or recurrent endometrial cancer has historically been the combination of Taxol and carboplatin. And although many women will respond to this combination of chemotherapy, the overall outcomes aren't the greatest. So the average or the median overall survival is less than 3 years for this at-risk patient population. Because of this overall risk, there has been a lot of research looking into how can we improve outcomes of patients either who present with advanced stage disease or who do recur after their primary treatment. And fortunately, in GYN oncology, there's been a lot of advances over the last 4 or 5 years. And truly, the standard of care for endometrial cancer is changing right before our eyes. This is just a review of the current NCCN guidelines for systemic therapy in endometrial cancer. And like I said, these have been updated over the last several years based on large prospective clinical trials that have investigated different agents in this space. As many of you may know, in March of 2023, 2 landmark studies looking at the addition of either pembrolizumab or dostarlimab to upfront treatment with Taxol and carboplatin showed a good improvement in progression-free survival. Longer-term data was presented earlier this year, and most recently, FDA approval was given to both pembrolizumab and dostarlimab in certain patient populations that present with advanced or recurrent endometrial cancer. In the studies that looked at pembrolizumab, in addition to chemotherapy, they did not include carcinosarcoma cell types, so those are not included in that current indication. But overall, any patient with histologies that were included in the study, so uterine serous, endometrioids, you can add pembrolizumab to upfront therapy in patients with advanced disease. Similar studies looking at Taxol and carboplatin plus or minus dostarlimab did include patients with carcinosarcoma, so those are included in the FDA indication. And again, the current approval is for all comers. The interesting thing about both of these studies is even though there was benefit to adding immunotherapy to Taxol and carboplatin, the patients that benefited the most were patients that have a mismatch repair deficiency. So truly a biomarker for response for these immune checkpoint inhibitors. Other studies have also looked at trastuzumab in patients that have HER2 positive advanced disease and also in carcinosarcomas. Now, one of the things that we wanted to address today and what we do here at our institution at MD Anderson is we really rely on a multidisciplinary team to help ensure that patients get the best care. Fortunately, for most women with endometrial cancer, they have a symptom like postmenopausal bleeding, changes in their menstrual cycle that they recognize as abnormal and they seek care. They'll often go either to their primary care doctor or to their OBGYN. And when a gynecologist sees these patients and they have these what we call red flag symptoms, a workup, including a biopsy, is often done. And so once they have a biopsy diagnosis of a cancer, then they're referred to an oncologist. So it does allow us to identify patients even before they come to an oncologist. Once they're seen by a G1 oncologist, our job is to understand where their cancer is at the time of diagnosis, and are they a good candidate for surgery, or do they have an advanced disease that would require some type of systemic therapy first. And that, either based on the biopsy or on the surgical findings, is when we really rely on our pathologist to help us with that next step.
Yeah, so speaking about a pathologist's duties, something I hear a lot is asking what exactly do we do? Pathology can be split into anatomic pathology and clinical pathology. Clinical pathology is anything you can think of that deals with lab or the blood. So you have a blood draw and it goes to the lab and they have to oversee the blood analyzers, the chemistry, et cetera. But also molecular, hematopathology, all these other aspects of pathology. Anatomic pathology fits into the realm of if you send a piece of tissue. So as Dr. Soliman said, whether that's the biopsy or whether that's a full hysterectomy specimen, a pathologist will look at the specimen itself, we call grossly overall, and then we choose areas of the tissue to put through. We have slides that get processed and come out, and then we look under the slides of the microscope, and then we can provide what does the tumor look like, if it is tumor or not, what's the histology, any warning signs then that could change how the oncologist may treat the patient overall, and decide if there's any molecular testing or biomarkers that may be warranted, or help troubleshoot those as we perform them here in our lab.
And then once we have the diagnosis and the stage, so where the cancer is at the time of diagnosis, we use that information to decide whether surgery alone is enough to treat a patient and they're low risk, or if the patients are at increased risk for recurrence, and what the role of radiation in partnership with the radiation oncologist, or adjuvant chemotherapy or immunotherapy, either done by some G1 oncologists, which is what we do here at MD Anderson, or some G1 oncology surgeons also collaborate with medical oncologists to administer the adjuvant therapy. And when we decide patients need adjuvant therapy, that's where people like Donyika come into play.
Yeah, so as the pharmacist on the team, I kind of serve as the drug information person. So I take into consideration the patient's specific factors, and we're able to choose a treatment that makes sure that we don't worsen any comorbid conditions, or that we follow those comorbid conditions closer. And then I also communicate a lot with retail pharmacists or specialty pharmacists to help for drug acquisition if we're using medications to help with side effects, or if we're using oral medications.
And so really there's a lot of members of the clinical team. So these are just some of the treating components, but there's also the MAs, the nurses, the nurse practitioners, other advanced care providers that are really part of our clinical team. And again, as the sort of treatment landscape gets more complicated, I think we recognize that every member of the team has a very important role to make sure that patients are getting the best care in the safest way. And so, like many teams, it's really important that communication is very clear. And I think that's why we all wanted to come here together, because we work very closely as a team. Donyika and I are in clinic 2 days a week, and we're talking about patients constantly. And I'm also nagging Barrett about pathology results and molecular testing kind of every week. So it's really important that we communicate, have this information. So again, with some of the changing treatments, that we're making sure that patients are getting not only the best care, but the most up-to-date care. And like I said, in the last 5 years, there's been a lot of changes to what we call standard of care treatment for endometrial cancer. And for us to sort of digest, understand, and provide that care to patients, I think now more than ever, it's really important to work together with the team. And so we're going to transition, and Barrett is going to talk a little bit about what we do as part of our standard biomarker testing at the time of diagnosis for patients with endometrial cancer.
Yeah, thanks, Pam. So we kind of go through a broad array of tests to help with biomarker testing in endometrial carcinomas, to help provide additional information in terms of how the patient may be treated or how we're going to disposition them in the end. So what we do routinely in our practice is upfront biomarker testing on the hysterectomy specimen, usually, maybe on an endometrial biopsy if we think there's enough tumor. And I'll just say that that's really at the discretion of the pathologist to help determine what specimen is going to be the best one to perform these tests on. Sometimes a biopsy is very small and it's going to be very limited, and you may not have enough tissue, versus then in a larger specimen, such as the hysterectomy, there may be more tumor. So they may get dramatically better results by performing it on just a different type of tissue. There's pre-analytical factors that we take into account is how well is the tissue fixed? Was it in formalin long enough? That's a very key detail, especially in breast pathology. They track how long the specimen's been in formalin. It has an effect on the immunohistochemical stains and the results that we get out of it. So that's something we have to keep track of in the lab. Now, for our immunohistochemical markers, and that's where we have an antibody clone that's been grown in a lab, and it helps identify certain antigens and what we're looking for. And it sets off it's conjugated to a stain that we can identify once it's bound. And so we can look and say, hey, this marker is then attached to this on the tissue, and therefore it's positive or negative. And usually with these stains, they have pretty good sensitivity and specificity. That is to know whether the chances of a positive is going to be positive or negative is going to be negative, to let us to be able to screen and interpret these results rather easily. And IHC, as compared to the other things on the list, as we get further to the right, IHC is cheaper, it's easier, it's faster. So these are things we like to start with to help screen. And if there's problems with these, then we can move further down the list for additional testing that might be needed. So estrogen and progesterone receptors are something that we do in all of our endometrial cancers, giving a percent and intensity that's needed for that. We'll jump down and say MMR proteins, the MLH1, MSH2, MSH6, and PMS2 are also done. And for those, we look for a loss of staining that may indicate then a mutation within one of the MMR proteins. And then further testing can be done to see whether it's related to a somatic mutation or methylation in the case of MLH1, or could this be germline, and thus the patient may have a condition such as Lynch and need to be tested for that. P53 immunohistochemistry helps pick up or detect whether there might be a P53 or TP53 mutation that is usually seen then in higher grade or more aggressive histotypes. HER2 amplification is good for then trastuzumab or anti-HER2 therapy. And so we look first screening with an immunohistochemical stain. If it's negative or if it's very positive, then we'll sign it out as such. But if it's in the in-between window, we call the 2+ or equivocal, we'll need to always then follow that up with HER2 amplification by FISH. And so the pathologist is responsible for looking at that stain, circling where an area of interest might be specifically, so we can test that and really focus on an area of the tumor where it might be picked up. And then we send that slide over, in the case of FISH, to our cytogenetics lab. I also sign out the FISH studies as well, so I do that. Carefully looking at where areas of amplification might be, counting the HER2 amplification as well as the centrometer amplification, and whether that be a positive to help qualify the patient for therapy in that case. As I said with the MMR proteins, if there's a loss specifically of MLH1, you always need to immediately reflex that then to MLH1 promoter methylation testing, because that is the more common reason why you have MLH1 loss, because that promoter is hypermethylated. And then if that's negative, then you would follow up with either PCR testing or NGS testing, specifically to look for mutations within the MSI proteins, etc. And then lastly, we see here is POL-E testing, which is actually incredibly important to the whole picture in the end. And so actually, if we go to the next slide, that leads us well into overall is this idea, not only with these IHC helping give an overview and screening for what the molecular classification is, but now the molecular classification overall is becoming more important in how we stage and understand endometrial cancer as a whole. And so POL-E mutations or it's I believe, a DNA repair polymerase epsilon. So that's what we call it, POLE, polymerase epsilon. A mutation in POLE, if you think about it in that way, since it's DNA repair, having a mutation in it leads to further damage of the DNA that can accumulate over time. And so when you have the POLE mutated and you get a report back from molecular testing, you'll get 10, 20, 30, 40 genes mutated, and the list keeps going on. And so if you ever have a report like that with multiple mutations, just go by the alphabet, look for the POLE, because it's going to be there. And that's a reason why it would have one of these ultra mutated type tumors. Now, when we work through this and kind of a cascade effect, POLE is the most important one to test for first, because if you have a mutation in POLE, it can cause problems downstream with anything else that we have listed here. So a POLE mutation, in theory, can cause a MMR protein mutation, or it can cause a P53 mutation. And studies have shown, though, in these cases where we have different mutations of POLE and an MMR and the P53, actually what happens is outcomes are based solely back onto the POLE mutation. So it supersedes everything in terms of outcomes, et cetera. So then the unfortunate side, though, is on the last slide, there is no IHC or easy testing for POLE. So you have to have NGS testing, molecular testing for POLE. So it's not as cheap, easy, and fast to have the POLE results first, even though it technically supersedes the rest of the results that you could get. With that, then, with this molecular classification, Pam, do you want to jump into then what these outcomes and what these differences would be for these patients?
Yeah, no, I think that's a really good point, Barrett. I think as a lot of these new molecular tests become available, I think we as the clinicians who are kind of prescribing drugs and deciding treatment do have to have like a basic level of understanding of the molecular testing. For what you said, I think, if you just looked at kind of the different tests and didn't understand how they could interact with each other, then you may treat someone with like a P53 mutation who's actually just a downstream effect of a POLE and may be sort of classified incorrectly. I think the other point that I think is important is that it's important as drugs get approved that are biomarker driven, that we're also using the right biomarker, right? So Herceptin's a great example. That's FDA approved for kind of addition or maintenance therapy in patients that are either IHC 3+ or have FISH testing. But the newer ADCs, like in HER2, that candidacy is based on IHC testing. So you can't just look at, is someone HER2 positive or negative? You have to understand where that testing comes from to understand kind of the indications for the drug. But to go back kind of generally, and I think anytime you split or lump, there's always some qualification, so it's not perfect. But I think kind of the early TCGA data and some of the standard testing that we're doing now does help us better understand kind of how endometrial cancers behave, what their risks are, what's the right treatment, more than sort of the classic histology, stage, depth of invasion, LVSI that we've used historically. And so, like Barrett talked about, there is a subset. I think depending on what study you look at, the percent of endometrial cancers that have POLE, I've seen anywhere from 4% up to 10%. But generally speaking, like Barrett said, it's a hypermutated tumor. When you get the next generation sequencing, like you said, it'll have like all these different mutations and you're like, wow, but it's all because of that POLE and inability to correct the DNA. Generally, it is associated with a favorable prognosis. So when you look at patients, even with advanced stage or high risk histologies that are POLE, they tend to be less likely to recur, fewer risks of death. And, it's just a different classification. So I think as more of this molecular testing becomes widely used, we'll also have a better understanding of when we can de-escalate care, right? So if a patient has a stage 4 endometrioid tumor that's POLE, like, do they actually need all of those, all the medications that we usually use, or can we de-escalate care? And there are some ongoing trials looking at that. Microsatellite instability, I would say, is probably the biomarker at this point that we maybe have the best understanding of. Like Barrett said, about 25 to 30% of all endometrial cancers that are diagnosed have a deficiency in mismatch repair. That can either be from a germline mutation in Lynch syndrome or from methylation of the promoter, which can have sort of the same downstream effect, which is the majority of cases. We know based on clinical trials looking at sort of mismatch repair deficiency in all types of cancers that immune checkpoint inhibitors really work well in patients that have a deficiency. That's the first approval, right? So mismatch repair deficient recurrent cancers can get single agent immunotherapy, and now it's being moved into the front line. And that again accounts for about 25 to 30% of patients. This third category, which we call copy number low, I would say is probably the most heterogeneous group. It's sort of everyone that doesn't have POLE or mismatch repair deficiency or copy number high, but it includes endometrioid tumors, the patients that are ER, PR positive, the ones that we've historically felt were lower risk. But I think based on what we know, there are a subgroup of these patients, even though they have low grade, low stage histologies that recur. Sometimes it's related to a beta-catenin mutation or other pathways. So I think we're going to learn much more about this particular subtype. And then we have the traditional P53 mutant, generally serous, high-grade endometrioids who tend to have the highest risk for recurrence and are probably the patients that would most likely benefit from some type of chemotherapy or systemic therapy. So again, kind of understanding what testing is being done, how we classify patients, both in the new staging and then just how we clinically treat them, does help us understand, which patients are more likely to either need therapy or respond to therapy if they do have advanced or recurrent disease. And then I think Donyika is going to talk a little bit about kind of the day-to-day, when a patient comes in and they need a new therapy, what are the things that we consider as a team? And again, how do we make sure patients get the best but the safest care? Donyika?
Thanks, Dr. Soliman. So there are a number of things that we need to consider when we're treating patients with endometrial cancer. I kind of like to put them in 3 different categories. The first category would be the therapy choice. So just kind of determining what setting we're in. So is this a recurrence of their disease? Is this upfront treatment? That'll help guide what we choose. And then any pertinent molecular testing. So all the things that Dr. Lawson and Dr. Soliman just talked about, we all take those into consideration too. The second category would be patient-specific factors. So those include their performance status. So do we think this patient can even tolerate like a multi-drug regimen, or are they more of a candidate for just one single drug? And then taking into account their comorbid conditions and their concomitant medications is also very important. So are we going to make any of their underlying diseases worse, especially when you're thinking of immune checkpoint inhibitors? So patients with diabetes, patients with rheumatologic issues, any kind of thyroid dysfunction, we have to take all that into consideration. And then lastly, just things about the medications themselves. So any important labs that we need to get at baseline, any kind of labs that we need to follow regularly, and then kind of explaining that to the patients and explaining to them why we're following those labs. And then lastly, the potential adverse events. So considering what side effects can happen, how we're going to manage them, and then how we're going to educate the patients and their family about that. Which kind of segues me into the next part, which is educating the patient. So once we've chosen a treatment, what do we want to tell the patient about the treatment? And so the first thing that we want to do is talk to them about the side effects. So that includes the signs and symptoms of the side effect in question. And so one of the things that I always reiterate to them is that all side effects can be managed and most of them are reversible. We just need to know about them earlier rather than later so we can take action. And then the second thing is always stressing the need to complete the pre-specified labs. I think if they know the why, they're more willing to do it. So one of the things I do is I try to let them know why we're following whatever labs we're following and then how often we're doing it and when they need to do it. And then just stressing the importance of keeping those lab appointments. And then lastly, just making sure they know that prompt reporting is the best reporting. So if you can tell us sooner, then we can take action sooner, and then hopefully we can fix whatever side effect it is and be able to keep you on therapy, because the longer they're on therapy, the better results they will get. So that's kind of one of the things I do on the team, is educate the patients and their family members about that.
So I think, as you can see, we all work together quite a lot. I would say kind of in GYN oncology, overall, I've been in practice for 17 years. I think kind of the importance of the multidisciplinary team has gone up significantly. I think as sort of newer classes of drugs become available, I think we have to work with pathology to understand like which patients would benefit from which treatment, either at the time of recurrence or if they progress on a current therapy. I think it helps us understand what standard of care treatments are there, and more biomarker-driven standard of care options are available. And then it also helps us understand if they're eligible for clinical trials. So, we always want to kind of discuss all options with patients, and many of the clinical trials now, both within GYN oncology or within experimental therapeutics in general, are biomarker driven. I think the second part of that is a lot of these new drugs are very different than historical chemotherapy that we've been using, the Taxol and Carbo and Doxil that we've been using for a long time. So as these new drugs become commercially available, we also have to understand what are the side effects. And, the side effects of immune checkpoint inhibitors are very different than the side effects of ADCs or chemotherapy. And how do we follow patients and be aware of their side effects so that we can manage them, instead of trying a drug that we know is effective, not managing them appropriately, and then they have to come off early or don't get the maximum benefit of treatment. So I think all of those things in my mind are why we've worked together kind of more and more closely over the last few years with the current landscape for endometrial cancer. So maybe Barrett, tell us a little bit about kind of what's the next generation of molecular testing. I think we see like even next generation sequencing has expanded, from 40 genes to 50 genes to 200. Do you have any thoughts on kind of where we're going to go with molecular testing and how that's going to continue to impact our patient care?
Yeah, it's one of those things, interestingly enough, that people keep bringing up the fact that NGS is expanding so rapidly, and as now we have this molecular characterization of endometrial cancer that's making such a big difference in terms of just prognosis for patients and for therapy, that, a normal anatomic pathologist might be put out of a job because he can just put that in, run the whole molecular, and you get the result. But I think it's really interesting, though, that it really is going to help marry the two together actually quite well. There's times where I've told you, hey, this histology doesn't make sense. It's very ambiguous. It looks like an endometrioid, but it's a little more atypical. What do we do with it? Where do we go? And say, okay, this is the time where we need molecular testing, because that could be a POLE, and then sure enough, it is. So I think that it's about not just the fact that we're doing this molecular testing or that it might be expanded, but it's about being very targeted with it, finding the right patients at the right time to do it, and when that might make a difference. And I think that's probably, to me, what's more important than the technology is about the utilization and timing of it, because it's expensive, it takes time. So where do we insert that for the right patient, get that done, and so that can come out at a good time that's going to be, the best impact for a patient's care, up front rather than, at recurrence down the road.
Yeah, so I think that's a great point, and I think it's going to continue to evolve. So I think, again, more and more it's important to understand, working with your pathology to understand the molecular side, and then working with your clinical team, to make sure that patients can get these new drugs, or hopefully the best drug for them in the safest way. So I want to thank you guys for joining us today. I have the benefit of working with an amazing team to keep me on my toes and make sure that patients get the best care. And hopefully you've learned something from us today. So thank you so much for your time.
Thanks.
Thank you.